Committee, and with me are Mr Laurie Hooper MHK, Mrs Anne Corwett MHK, Mr Rob Mercer MLC, Mr Jason Morehouse MHK, and the Tynwald Auditor General Mr Stephen Warren. Today we're meeting with the Chief Executive Officer for Manx Care. Welcome to the oral evidence session. For the benefit of Hasan and those listening, can I ask you please to introduce yourself, including your title and how long you've been in post, please?
Thank you. My name's Teresa. I'm the Chief Executive of Manx Care. I took up my role as Chief Exec Designate on the 1st of December 2020 and then resumed Chief Executive of Manx Care on the 1st of April 2021 when the organisation commenced.
Thank you very much. Mrs Corwett.
Thank you. So we're going to start with the mandate and the budget. Some questions here. When the Chief Minister took over as DHSC Minister, he identified the key weakness as being a lack of alignment between the mandate, the operating plan and the budget. So do you agree that that was the biggest challenge?
Yes, I do, in terms of being able to give really strong assurance that the services we were being requested to be delivered could be delivered within the financial envelope of the settlement. I think there has always been very strong alignment between the ambitions of the mandate and what we would like to achieve through the mandate. So across the 5 years, I think there's always been real strong consensus about the types of services. But yes, I think because of some of the limitations of our financial systems and the lack of, I guess, strategic commissioning capacity, that key question of can we really deliver this level of service for this amount of money has been very difficult to answer for both Manx Care and the DHSC.
So do you think that the challenges of aligning the mandate, operating plan and budget have been achieved for delivery in 26-27?
I think we've got much closer. So obviously for the 25-26 mandate, when we brought in the improvement directors, there was a sort of a concerted effort to get much closer to answering that question: what does the financial envelope buy? In terms of activity, in terms of transformation, and what can sit within the control of Manx Care to influence, so things like productivity and efficiency, and what are the financial risks that sit outside of Manx Care that it has no ability to control. And I think with the help of Peter Shanahan and Sean Stacey, we came much closer to being aligned about what the money could buy. And I do think there were some issues in that what the operating plan and the mandate said for 2026 didn't happen in reality. And the example I would give is pay settlements. So we were, both DHSC and Manx Care were very clear that pay settlements above the standard budget allowed, we would have to go back for more money to be able to settle those pay disputes. But we did not achieve resolution on that. And so consequently, the supplementary vote, which will come to Tynwald, will include what Manx Care had to spend extra in order to achieve pay settlement, which does make our position look much worse than what it would have been. For 26-27, again, we worked really closely with the DHSC, and I believe there were fewer areas where we were acknowledging a level of financial risk. And Minister Christian was very clear, if we didn't have a clear funding stream, it wasn't to go in the mandate. So I do think this year we've got A, a better settlement with a 12% uplift, and B, there are less areas where we are exposed to financial risk. So 26-27 does give us a stronger chance of operating within budget. However, there are still some significant risks, and pay I would still stand out as being one of the biggest risks in terms of what we're funded for at 2.9%, what we've been able to create in terms of contingency within the budget to be able to flex that a little bit. But then we have unions whose expectations way exceed that. So how you find the gap between 3.5% and 8%, that's several millions of pounds worth of gap, which I don't think any of us would be clear how we would close that gap without impacting frontline clinical services. And so those are the sort of key risks and discussion points which are very much live and active, and we're committed to resolving.
Can I just pick up on that particular one you said about pay? I mean, I appreciate in recent years pay has been an absolutely massive issue, and I'm just looking specifically at doctors, and for 2022 that was 6% and £1,000 increase. For 23 it was 8% increase. 24 was 6%, but for last year it was only 2%. And that's only in the doctor cadre. I appreciate it, so I haven't got the figures in front of me for nurses and other. But how much of this supplementary vote will be around pay? And hopefully those figures are right. They were.
Yeah, the doctor pay was a 6% and a 2%. The 2% came in February, so it was a split year deal. Yeah, no, you're correct. And we have seen over the course of the last 5 years some very high inflation, which is translating through into pay. So across hospital, medical and dental staff and MPTC staff, which are responsibility of Manx Care to negotiate, those pay uplifts have been 26.75% across 5 years. And that has equated to £60 million. So if you think about the totality of the acknowledging the substantial uplift in settlement that Manx Care has had over the last 5 years, 135 million has gone into health and care over the last 5 years, but £60 million of that has been consumed just by meeting the pay awards. We've also obviously seen contract and consumable inflation outstrip the budget that is given to us. So again, about the same amount has gone in sort of contract inflation, new services, safe staffing. So, I sit here today reflecting that health and care have had some generous uplifts over the last 5 years, but they haven't met inflation. And in many ways, they're sort of creating a bit of a standstill position.
I'll bite my tongue and let you carry on, Mr. Corbett. Loads we could ask on that.
Sorry.
No.
So could you talk us through your input into the mandate process?
Yeah. So I have oversight of the mandate process. 2 of my executives have the lead responsibility for it, but with support from the clinical side. So sort of our Director of Partnerships Improvement sort of takes the lead role, supported by the Director of Finance, who are then supported by the Director of Operations, Medical Director and Nursing Director. And I have an oversight view. I mean, this year, our team was largely consistent. So people who'd done it 2 or 3 years. For the DHSC, they were in a position where it was new people leading that process. So I've got a timeline of all of the interactions, but we worked incredibly closely. There was the plan to bring the mandate to Tynwald in February. So there was a huge amount of work done over the Christmas period in order to prepare the operating plan and the mandate side by side and allow for that to go through governance in January through the Manx Care Extraordinary Board, which was scheduled for the 6th of January. As we know, that didn't happen, and ultimately the mandate and the operating plan were laid together in April. And at that point, we were able to confirm what the budget was and what we had been funded for. And we did present 4 scenarios for funding, based on the absolute sort of baseline pink book, which was, would have meant us quite a significant retraction of services. The 404, which we got, which allowed us to do the core mandate deliverables and some investment. Our ask was 425 million. That would have been a 17% uplift. So we presented those 4 scenarios as to what the money could buy.
Okay. And so for 25-26, was the budget allocated sufficient to deliver the mandate?
No. Obviously, what was helpful was the £10 million worth of contingency, which allowed us to look at those costs which are fixed and not controllable, and agreeing with Treasury what type of costs can legitimately go against that contingency. So Section 115, aftercare, high cost care packages. So those types of costs it was helpful. It was helpful in terms of determining just how much those costs add into our system, which are out with our control. Other elements which did affect us was some of the pay elements, the vaccine service, the Logan Air subsidy. All those things were left hanging. What we attempted to do in 25-26 was to absolutely be clear what was in our control and what wasn't. But as I've said previously, the ability to get resolution on those loose ends was quite difficult. So in our management accounts, I think that caused some problems because we were reporting what Manx Care would say was the overspend in terms of the bit we're responsible for, the operational overspend. But there was a number of costs beneath that line where we attempted through the course of the year to seek resolution on how those elements would be funded, which Manx Care was saying those are not costs that we have signed up to as part of the mandate and operating plan for 25-26.
So how is this going to be different for 26-27?
So I think we have been much more... So in 25-26, for example, I guess in good faith, both DHSC and Manx Care made some assumptions. For example, we expected to get a level of transformation funding, which we had been clear about how much that was and how that would be deployed, and what the return on that transformation investment would be, and what we anticipated to have as the impact of that. So, for example, we wanted to do a programme called Getting It Right First Time, which drives out clinical productivity. It's a recognised benchmark of how you get good productivity into clinical practice. And that was fundamental to us in terms of making the best use of the resourcing Manx Care has. That's almost our side of the bargain, to demonstrate effective use of resource. We also wanted to validate the waiting list. We know our waiting lists are long, but we also know they are not what we would call technically clean waiting lists. And it is poor use of resource to start doing extra clinics and extra activity until you have validated your waiting list, both from a technical and an administrative administrative perspective, but also from a clinical perspective. And again, we wanted to invest in clinical validation. The business case we submitted for clinical validation, it's basically £12 per validation. That is the best use of resource, and evidence tells you you can reduce the waiting list legitimately, appropriately, with good clinical pathways and diversions by 30 to 40%. So that single interaction would have absolutely helped the overall waiting list position for the island. It would have allowed us to create new patient capacity alongside something called patient-initiated follow-up and reducing the follow-ups from our system, so unnecessary follow-ups, and that's where you target validation. So this isn't novel, this is accepted practice, and indeed good practice in England is that consultants are expected to do a full validation of their waiting lists every 6 months, really, to give the assurance that the waiting lists are clean, and then you can plan your capacity and demand and your services effectively on clean waiting lists. So those were just two of the examples of how we would wish to use transformation funding in 25-26 to really have impact on one of the biggest priorities for both DHSC and Manx Care, our waiting lists. And unfortunately, we did not get approval for that transformation funding until month 10, 11. And that's unfortunate because we could have been in a much better place, but we are where we are. I recognise that level of resourcing. I think it equated to close to £2 million. Is a big slice of transformation resource. But we had been explicit in our mandate and operating plan for 25-26 how critical that was and the impact that would have, which is unfortunate. And I guess neither DHSC or Manx Care could have predicted that it would take so long to get that approval, because I know Mr. Stacey and Mr. Shanahan did extensive workshops to be able to understand the importance of that, but I guess we are where we are.
Can you just clarify something you said there? You said about sort of £12 per patient as part of the sort of waiting list cleanse. Is that Manx Care paying its consultants to £12 per patient to validate their own waiting list?
No, it's basically the level of resourcing we requested, which would be sort of administrators and extra capacity around that, and then obviously planning that into consultant activity. So it would. So the total of the business case, we were going to get through 80% of the waiting list. I have got the numbers somewhere, Mr. Watterson.
So it's okay, I'm just trying to sort of understand a bit of, but the money is being paid, it's extra money to go into the people who are supposed to be dealing with the waiting list have to be validating, because it has to be clinically validated, surely. It's not administratively validated.
It is both. It's right. Both steps, but actually, the investment we requested, when you look at the thousands of validations we were going to do, it sort of worked out. I mean, it's a very crude assessment about the totality of the money requested against the number of validations we were going to do, but that's what it worked out at. And it's to try and demonstrate that if you put on an extra clinic to see 15 follow-ups, you've got a doctor, you've got nursing, you've got all of that resource, but actually if 5 of those didn't need to be with you because they've already been seen or they've got a different pathway. Yeah,
I'm just trying to follow the money, that was all.
Yeah.
Okay. We're paying people a circular argument, but sorry.
Yeah, and it would be our clinicians, and what we recognised is some of our clinicians absolutely are used to validating and have got really good skills in that. And a very clear methodology, and perhaps some of our clinicians who haven't been used to doing that validation might need some assistance with that.
Okay. Thank you.
Do you mind if I just ask on that validation, from reading through the operating plan, I thought the intention was to include in the clinicians' job plans a certain number of PAs to do clinical validation. So it shouldn't have been extra money above and beyond what they were already earning. It's just rejigging their existing job plans to include validation.
It is, yes. And indeed, what we should do and are doing in job planning is making this a fundamental part of job plans moving forward, so we don't end up just doing it once and then allowing that sort of non-clean waiting list position to grow.
So we can see from the operating plan notes that the expected spend for 24-25 was 362.3 million. And that was already $500,000 above the budget allocation for the 25-26 year as per the operating plan. So was that a realistic budget?
No, it wasn't, and hence why there was such efforts to stipulate what was outside of that quantum for transparency purposes. And indeed, that's why the £10 million worth of Treasury contingency. You know, I think we were given a very clear brief by the Chief Minister, and all of our efforts over those months and weeks with all of the workshops which you were all invited to, was definitely attempting to demonstrate how we would operate within that budget. There was some significant assumptions, the use of transformation being one of them, the success around removing costs from the system, a very ambitious CIP plan, all of those things, which effectively did mean, I think, we were going into 25-26 with quite an ambitious plan. But it was the department and Manx Care working with absolute best endeavours to try and demonstrate how we were going to address productivity and efficiency. We were very mindful of the value for money question and the views of the public and politicians in how we demonstrate that. We could see that there's opportunity around grip and control internally. And we were also clear about what didn't and couldn't sit within the control of Manx Care, but that may present financial risk. So I think what we attempted to do was do as much as we can to say how we would operate within that budget, but also to be clear about the risks and the dependencies of some of those decisions. I think we all knew it was a big ask, but quite frankly, we were all committed to try and do our very, very best. It's very difficult, almost impossible, to switch off costs and services. So yes, I think that's fair.
Can I ask on that before you even move on? There was a number of things as part of the mandate that you deprioritised, and it's listed in the operating plan. The one that's relevant here, I think, is activity-based costing. And so originally there was always the intention to make sure that we had some way of accounting for what services actually cost to deliver. And the methodology that was talked about was activity-based costing. It's just the terminology that was used. But in the 24-25 mandate, the one we're talking about, actually it was deprioritised. Do you not think that perhaps, given that there was such a focus on finances and understanding the cost base of Manx Care, that a decision to deprioritise the only methodology that was that would let you do that, get a better handle on exactly what things were costing, do you think it was a good idea to deprioritise that at the time?
We've had this debate, and activity-based costing would be incredibly helpful to us. PLICS, patient-level costing, would be incredibly helpful to us. It would take away or demonstrate value for money or not. It would remove all of the subjectivity that there is on this matter. Activity-based costings needs a comprehensive clinical coding as a background. As you well know, we only started doing some clinical coding when Manx Care started, and it has evolved year on year. But to do activity-based costing, you need a backdrop of comprehensive clinical coding. You also really need an electronic patient record, the Manx Care record. We are still writing requisitions on carbon paper. So the financial systems that we have available to us make activity-based costing impossible, in my opinion, and that is also the professional opinion of the accountants that I work alongside. So I don't think we were deprioritising it because we didn't think it was important. We were deprioritising it because we didn't think we'd get anywhere close to realistic activity-based costing, which would come anywhere near helping us to define the true costs of care. So we could have put an awful lot of resource into something which didn't yield very much benefit. And if there is an alternative professional judgment on that, then I would be very receptive to hearing it. We now have the financial recovery plan, and we have an expert team with us who are starting to try and get that resourcing and start to take us a little bit closer towards activity-based costing. But it is still in its infancy, and this is a team, a very expensive team, but a very highly skilled and qualified team, but costing around £750,000 a year. And they are helping with a broad range of work on the financial recovery plan, of which activity-based costing is one of them. But it does need, in my opinion, comprehensive clinical coding and electronic patient record are the two fundamental requirements of AABC.
Okay, well, conscious we only have Ms. Cope with us for an hour, so we may need to pick up the pace, but Mr.
Okay.
Hooper.
Sorry, and I'll try and be a little bit more.
We'll all try.
We'll all try.
So in the 25-26 budget, the allocation that was presented to Tynwald in February in the Pink Book that Tynwald actually approved was £357.5 million. But the operating plan that was laid before Tynwald a month after that says it was £361.8 million. Why are those two figures different?
I believe they're different because we were given money in the baseline to fund the medical and dental pay settlement. That was part of it. I don't have the detail, but I think there were 3 or 4 things which fundamentally meant they were put into the recurrent position, of which that was, I think, about £2.3 or £4 million were the recurrent impact of the pay settlement for doctors.
Okay, and the full difference was 4.3 million, and that was the entirety of what was described in the budget as the other line. Just other was the description. But obviously that wasn't Tynwald approved. Tynwald was asked to approve a mandate of 357 million. That isn't actually what was then presented to Tynwald as part of the operating plan. So at what point was that decision actually made, do you know, to allocate additional resources to Manx Care above and beyond what Tynwald had approved?
Gosh, I'd have to check, but I think it was sort of quite late into that process. And I think that arose, but certainly we were in negotiation with hospital, medical and dental unions in parallel with the development of the mandate and the operating plan. So that was happening around the same time, January, February. There was a reconciliation point where we actually understood the true recurrent costs of that pay settlement. And I'm sorry, I don't know the detail around the other aspects, but certainly, you know, I think it was a symptom of the fact that these things were happening in parallel, and we were attempting to negotiate with the department to say, look, we've collectively agreed that we need to settle this pay deal, but we do need to have that in our baseline position. So I think that was the shift.
Okay. As part of that budget as well, there was an additional 10 million, which you've already talked about. It was allocated in contingency to the department and to Manx Care. Do you know at what point it was decided that 10 million contingency would need to be spent? At what point did Manx Care say, actually, we're going to need to spend this?
So I think we identified very early on, actually. So it's like anything. We would have wished to have used it purely as contingency and understood and only drawn it down when required. However, the operating plan, again, was very, very specific that things like high-cost patients, care packages, the uplift between the social security payment and what we have to pay for patients in residential care, Section 115 and GNAS, all sat as sort of costs which we didn't have the budget for, and that's why they've sat beneath the line. We agreed the terms of reference of how the contingency would be used quite early on, and that was a really helpful discussion and clarity, and then we were able to track the costs of that and submit that. So that's why in the accounts you see those six areas reported separately to the operational expenditure of Manx Care. And I think that's been helpful. In this year's settlement, we made sure that those are now in baseline budgets, because whilst there is programmes of work to look at how Section 115, for example, might be funded differently in the future, there is no immediate solution to that. So that has now gone into our baseline budget positions. So we're not using non-recurrent Treasury funding. One of the things we both flagged, both Manx Care and DHSC, last year, which again was helpful and therefore it did manifest itself in budget setting, was none of these costs are non-recurrent. So if a patient is in receipt of 115 aftercare, that only stops when the patient dies. So that is not a non-recurrent. High-cost care packages, those residents can often be in those placements for a number of years. If they're directed from a prison, a high secure forensic placement can be 5 to 7 years. So I think there was a very early conversation to say, whilst we're putting this against contingency, these aren't non-recurrent. They need a recurrent solution, which is why we've now got those in the baseline budget.
The reason I ask is because obviously Tynwald approved a mandate budget of 357 million, but actually when you add up the contingency that it was always intended was going to be spent, you add up the extra money that the department gave post-budget, actually the budget that was actually handed over to Manx Care was 371.8 million. It's actually considerably more than Tynwald had approved, and that all happened almost behind the scenes. There was no open acknowledgement that this had actually happened. And then when you take that and look at the actual spend in that year, according to the current budget, you're looking at a figure of 384.5 million. So we've heard this year already there's been a substantial increase to just over £404 million, I think, which sounds like a really big increase from last year's budget to this year's budget. But when you actually look at what was really allocated in the budget, what's really been spent, you're really looking at an increase of only 19.7 million, which is considerably less than the £45 million headline number that we've all been seeing being splashed around. Do you think that's really a reflective and fair way of presenting Manx Care's budget in that big glorious £45 million headline? Actually sounds great, but actually when you look beneath the surface of what it really represents, it's less than half that in actual terms. That's before you factor in medical inflation and all the other issues that you talked about.
No, yes, I would agree. I don't think it is fairly represented, but I don't think that's new. And we have been really clear that the 406, the scenario we presented of one of the four, that allows us to do the core mandate only, assumes a 2% cost improvement, which is obviously what we're mandated to provide, and it doesn't really allow us to invest greatly in anything other than what's already been in the baseline position. So if we think about what we're likely to achieve in terms of pay uplifts, inflation, then no. I mean, but I have to also recognise our responsibilities around the wider government finances. So there's that balance between the we've got a 12% uplift, and that's better than most of the government departments. But actually the reality is that does mean we've got to be really, really careful on our expenditure. And we can't be promising anything particularly heroic during this year in terms of massive reductions in waiting list. As I say, I still firmly believe that Manx Care can make improvements around things like validation, getting it right first time. But there's also a cultural requirement to support that level of clinical change in behaviour, which actually will, in reality, drive out some of those benefits and create that capacity for our patients.
Thanks.
Mr. Mercer.
Thank you. The topic heading here is changes to the mandate. So, are you being asked to deliver any services that are not in the mandate? And if so, what is the process for that?
I think we have worked incredibly hard this year to get the alignment between the mandate and the budget. There's only now one or two areas where they're left unresolved, but those are being addressed, so they're actively being resolved. So one of them is around homelessness, and that's sort of that responsibility for both the service and the costs of emergency accommodation sitting with Manx Care. That was a late addition to the mandate after the budget had been settled, but again, the DHSC is supporting that through a process. The other sort of area of risk, yet again, is that we need to request formally through Treasury the rollover of the funding, the transformation funding. But again, that's also in a process. So we obviously do believe what we've been asked to do in the mandate is broadly affordable. But again, there are always assumptions sat behind that deliverables. And of course, things happen. We're very clear as a board, we are not going to overspend on the 404. Which means that, and that 404 is predicated on us achieving just under £10 million worth of cost improvements. And we need the financial recovery programme to kick in later in the year. So we still have financial risks in our system, both in terms of operational demand, responses to higher inflation around drugs and consumables, particularly in light of what's happening in the Middle East, pay uplifts, and just the level of operational pressures. We've extensively planned for TT. We're ready. High quality plans in conjunction with the Northwest, but it is actually going to cost us a lot more to have the same level of support from the Northwest that we have previously enjoyed and that we need. And that's why, the motorsport costs, we've increasingly been transparent about what the true costs of those are, because those hospitals in the Northwest have to staff up and skill up, and they have to pass the costs on to us. So yeah, it's not without risk, but I think it's the year we have come closer to something which we both feel is realistic.
You mentioned earlier that the 404.2 million allows you to deliver the core services. Who decides what's core, or what's the outside part of it? Is it peripheral service?
Yes, I mean, I think the core offer is what's already there, and that you can't change. So there is no there is not a lot of new services or additional investment. It is what is currently there. So I would describe it as a consolidation year. Let's keep on our committed ambition around Home First and move into the community. We've got some modest investments. We're targeting that around Home First, GP access, dental access. But there is no big change of delivery. There is no massive injection of funding. Both DHSC and Manx Care really wanted this year to be the year where we demonstrate we can operate within the money.
Okay, so when you're talking about core services, you're talking exactly about everything that's on the mandate, but nothing new that comes out of the woodwork.
Absolutely.
Right. Okay.
We have, if it's helpful, we have applied investment. So some of the schemes that were previously funded by transformation are now in our baseline position, so they come out of the 404. Things like intermediate care, which has been running for 2 years, very successful. We wouldn't want to turn that off. It's having great impact. So we've funded that, and that's 1.3 million of our investment. See and treat in the ambulance service, 655,000. So again, no longer funded by non-recurrent transformation funding, now funded within our baseline position. We've got some vaccine delivery in there. We have got our ATU, our same-day emergency care service, again, now funded through our recurrent baseline, and the development of our clinical decision unit. So in terms of where Manx Care are currently applying its investment, there is £7 million worth of investment going in, but actually a lot of those services already exist because they have been funded through non-recurrent transformation previously.
Okay, thank you. When it comes to any changes that come up, who's responsible for costing and risk assessing those changes? Is that
in terms of new services?
New services, yeah.
So if we were asked to deliver a new service, the mandate would say DHSC describe broadly what they wish to have, and Manx Care would do the how. How would this service be developed? So, for example, we wish to develop a clinical decision unit in order to support our emergency department, which isn't about admitting patients to hospital, but it is about allowing patients to have same-day emergency care that does take longer than 4 hours. That is a model that Manx Care are describing, impact assessing, recruiting to, and it is largely up to Manx Care how we would deliver that using our clinical expertise. So we would always want to make sure that what we're doing the DHSC is comfortable with, and where we want to make a service change or it's appropriate to have public involvement in, we would do that. But genuinely, I think we all understand what a clinical decision unit needs and looks like, and the impact we expect it to have for the community.
Thank you. So how are the mandate and the budget updated to reflect any changes to services? And I'm thinking here maybe the addition of services or the removal of services. Yeah.
So the removal of services is difficult. We would need to formally consult with any service that is permanently removed, and we really haven't gone down that route. We have had to do some temporary cessations, and certainly the Ramsey position has meant we've had a number of those to have to contend with over the last few months. We track mandate delivery through our governance routes on a quarterly basis. So there is a mandate meeting monthly, and the board receives a quarterly report which gives us assurance at the board level about how we're delivering against each of our mandate objectives. We have a clear plan which we have submitted to the department this year, which is basically our sort of project plan for all of the mandate deliverables to make sure we can evidence we are tracking that. Because we are very conscious of the money, we are not initiating any of those until we are clear on the position. So we're still building our cost improvement programme. We still need to get our operational run rate under control, and therefore the deployment of applied investments and additional things for the mandate will happen once we have the assurance that the funding is there, and that we've got our baseline position under control. So, for example, if our run rate is not under control at month 1, then that would prompt us to think about is it still appropriate to continue with recruiting to staff for clinical decision units? Because we've got to keep within the operating budget. We will not start the work associated with the transformation funding until we have got categoric assurance from Treasury that rollover has been approved. So that has resulted in a 6-week delay, but I would be operating against financial instructions, and it would be a cost I couldn't reabsorb if Treasury were to say, actually, no, we decline that rollover. And I think history has told us in Manx Care, we have taken risks to get work underway previously where resourcing has not come through. And that has left us financially vulnerable. We have overspent, and of course there's heavy criticism of that. So we're being much more cautious now, because what we've learnt is we can't assume those things genuinely do follow through.
That's great, thank you. Just supplementary to that particular one, has Manx Care received any statutory directions from the Department of Health and Social Care?
I don't believe so.
And finally from me, when changes to the mandate are being proposed by Manx Care, for example, to enable the delivery of savings, or by Department of Health and Social Care, for example, when Tynwald resolved to do something new, how do you address those challenges and resolve any tension that can create?
Yeah, so we are taking, so I think the example I would give is the non-emergency patient transfer, which has been a long and protracted process. We know there is a significant gap between what the service is currently being cost to deliver in the DOI and ultimately what it would cost to deliver that same service in a highly regulated health and social care environment. Manx Care, supported by the DHSC, have always been clear that we wouldn't take on that service at financial risk. And the board have been very, very clear about that. And I think that's where we are in terms of, Manx Care takes huge reputational damage from overspending. And therefore, I think we've become increasingly cautious that unless the money has been secured, and we have that in writing and we have that in our position, we're not going to proceed. And that includes capital investments as well. So again, a great disappointment is that our endoscopy equipment, which we had to buy because it was more than end of life and couldn't be used anymore, so it's a patient safety issue, it's capital funding, that again is going into our supplementary vote position, which isn't a good position, because it does inflate the level of overspend of Manx Care unnecessarily. But it's £2 million worth of capital investment for new endoscopy equipment, which had to be bought over 12 months ago for patient safety reasons. And DHSC have been incredibly supportive of describing this in detail, but I am concerned that everybody just sees the overall number and not the detail which sits underneath it.
Thank you.
Mr. Whitehouse.
Thank you. I'm moving on to actual cost of service delivery. The first thing I'd just like to make is that endoscopy equipment. 2018, didn't we get all new equipment and a whole new suite and
No.
Go on, sorry,
No.
go on.
The endoscopy equipment was over 20 years old. It was way past its useful life, and we had an inspection from JAG, Joint Accreditation Group for Endoscopy, and they essentially supported us by saying that equipment is not fit for purpose. So we had to, through our risk management committee and our board, agree that had to be purchased for patient safety reasons, which is what we did. So no, there was no brand new endoscopy equipment in 2016. The unit, I believe, did move from Ramsey down to Nobles, but again, it was not a brand new unit.
Right, thank you. Earlier you referred to the core services being relatively fixed. Are the costs also relatively fixed, or is there some movement within that?
The costs are largely fixed. If you think about health and care, around 77% of our costs are our workforce. They have contracts, they have rights of employment, and therefore they are largely fixed. So we, through transformation, do want to progress, looking at different clinical models which deliver different outcomes using perhaps different workforce. But we have to be incredibly mindful. We have substantive workforce, and if we are going to do that change, we have to negotiate and consult around those changes, and we have to go through organisational change policy in order to do that appropriately. So it's not easy to change clinical models because you are changing your workforce and you have to negotiate their terms and conditions differently.
Thank you. You spoke earlier about the activity-based costing and the team that are taking responsibility on for look at costings as an alternative. That's costing $750,000 a year. Could you give us any insight into what that's consisting of, please?
So I think this might be better answered by Mr. Hasan when he joins the Department of Health and Social Care session. He is our strategic finance director. He is leading the financial recovery programme on behalf of the DHSC, and he can probably talk in much more detail around the expertise he's bringing in and how that work will support those longer term financial savings. So we are working on a much more of a 3-year plan rather than sort of in-year, the salami slicing approach to cost improvements. So I think he might give you a better answer, I think.
And at this stage, do you feel confident in terms of, you have a better idea in terms of what services cost, and in terms of assessing those, you feel more confident that the person taking on your role will be able to have more clarity in terms of going forward in these core areas?
So we've come an awful long way over the last 5 years in terms of data and being able to use data to understand our costs. But I think have I as answered before, the lack of clinical coding, it's difficult to benchmark, and our current financial systems and the lack of the electronic patient record make it really, really difficult. If we were a maturer system undertaking strategic commissioning, the ideal situation you would have for a service is you have a service specification. You know what the service that you want to commission looks like. You've got a specification. And you have that service specification costed. It tells you what the workforce you need, the activity you're going to deliver, the consumables and equipment that you will need to deliver that service. And you cost that from the bottom up. And therefore, you are commissioning that. So there is complete transparency about what that service looks like, what it costs, the workforce you need to have to deliver it, the activity, and you can then assess and benchmark whether you're getting value for money from that service. And you can look for comparators. Very hard on an island, but you can look for comparators about whether that service looks particularly expensive against comparators or it's value for money. We don't have any of that here. You know, and we've recognised that time and time again, that doesn't allow for us to have the level of transparency and indeed politicians, yourselves, to have assurance on value for money, because we don't have the tools to give us that. We're building the data. We are getting much closer. But we genuinely are way behind where other systems are in terms of being able to really demonstrate that. We know there are some inherent inefficiencies and opportunities for productivity in our systems. But in terms of what it costs and the infrastructure to deliver services on an island setting and the resilience you need, I don't think we've come close enough to be able to answer that to anyone's satisfaction.
Thank you.
Yeah. You recall in January, February last year, when Manx Care knew it wasn't going to meet its financial targets, there were some quickly developed proposals which ended up not being accepted by the Department of Health and Social Care or the Council Ministers. These got into the public domain, unfortunately, and ended up with this committee. That seemed to stem from a lack of understanding on Manx Care's part about what perhaps the council and department was willing to accept in terms of cuts, but also perhaps from department and Comin's part about the difficulties that Manx Care had about meeting its budget. There just didn't seem to be an alignment of thinking, I suppose, between all of those three elements at that late point in the budget year. What do you think has been learnt from that, from perhaps Manx Care's perspective at least?
I think it is incredibly difficult to make financial-based decisions in isolation. You know, as an arm's length organisation, we would wish to take the responsibility for taking steps to mitigate our finances. At that time, we had agreed a £15 million maximum control total of overspend, and we had to give a written assurance that we would not go any more than £15 million overspent. And therefore, the board did what any board would do in that situation and agree what extra measures it would take not to breach that £15 million control total. Inevitably, at that point in the year, you've only got a couple of months left, you're not awash with easy solutions to try and take out significant amounts of money to maintain that position. And therefore, ultimately, the only way you can manage at that point is elective activity. You can't turn off any other activity. And most organisations, most NHS hospitals do use elective slowdown as a legitimate way of curtailing costs during winter, particularly when they know that they've got increased demand and increased costs in the system during winter. The learning point is clearly, whilst that decision is understood by the board and being prepared to take by the Manx Care board, it is really important those decisions are signed off by the Department of Health and Social Care and indeed Comin, and there is that joint working so we all can stand behind any decisions which, quite frankly, are unpalatable, not easy to make, and do result in a lot of anxiety and upset of the public and impact on patients. And we are in that position repeatedly, and we will continue to be in that position of having to make some very difficult choices in order to operate within the financial envelopes we have. I think we have worked incredibly hard over the last year to agree how we do some of that. But yes, that was a significant learning point for us all.
Can I just ask, when you received that, you were asked for that written guarantee that you wouldn't go more than 15 million over the budget. When you were asked for that, do you think that the people asking you for that commitment knew what it meant? That they would have been reasonably expected to understand that that would have meant an elective slowdown at that point in the year? Because, like I said, there's not a lot of options available to you.
I don't think that they would have necessarily understood that would be the action. So whilst it's sort of obvious to me as a health and care professional, I think it is a very contentious, and you know what we have and what we certainly had at that time, because this was pre our Otter system around tertiary activity. Tertiary activity is incredibly volatile. This is the activity that goes off island, and all you need, and it's not even about how we manage that process, all you need is a large major trauma centre case or a transplant case or a heart and chest case, and you can swing your costs of tertiary delivery by up to £2 million in a month. There isn't sufficient flexibility in the budget to manage those levels of swing in tertiary expenditure, and of course you're never going to not send that patient or not do that activity, and therefore you're left with some very difficult decisions if you really are going to stick within a certain budget. But that is just, that is the life of health and care. And that is where I think we need to get greater understanding of what costs you can control in a health and care system, and what you can't. Because we're never going to deny any patient, resident, service user access to the care they need at the point of delivery when they need it. So you have to take different steps in order to curtail budget. But like I come back to, when your workforce costs are quite fixed, those costs are hard to get out.
Not wanting to relinquish my reputation as one of Tynwald's biggest pedants, when we were talking earlier to Mrs. Corwett about the challenges of aligning the mandate, the operating plan and the budget, the quotes I note down at the time, and I hope they're accurate, but that you're much closer to having them aligned, and that there were, quote, fewer areas of financial risk. That still sort of gives me room for manoeuvre, and I was wondering, in terms of the gap, I know you've talked about any increase in staffing, but was there any other areas there that you actually are very concerned about not being aligned?
I think pay is the biggest issue. Pay, we could be several millions of pounds worth adrift between what we've got to fund pay settlements and what may well be needed to achieve that.
Okay. And finally, perhaps just a sort of big question to sort of sweep up what's been talked about today. In terms of that alignment, you've got the mandate, the operating budget plan. They're supposed to all sort of come together at a critical juncture around the budget time and then into April to provide a coherent vision. Given that there has been some quite significant mismatches in that over the last sort of 5 years, how does Tynwald get assurance as to which one is going to be is going to prevail? Because there's not a great deal of understanding as to what's going to be cut if the budget doesn't come along. So what's happened is that every time the budget is the thing that's given, not the mandate nor the operating plan. So perhaps some thoughts from you about how we as politicians should be getting that sort of assurance over how these three elements do actually interlock rather than just sort of vaguely interact with gaps.
Yeah. If there is one thing which fundamentally will help better manage the finances moving forward, it is a very clear health and social care strategy for the next 10 years. What does health and care look like? What do the policy frameworks look like? At the moment, we are just delivering what we've been asked to deliver against rising demand, rising costs, and we don't necessarily have the leverage to make the level of substantial changes which we need. We need to have a much bigger strategic conversation with our public about, and the honesty about, what services need to look like in 10 years' time, and do that thinking. I think we've started it with the left shift, but there are a lot of unanswered fundamental questions, and I think we've got a lot of policy and legislation based decisions to make, which will ultimately give a clear direction about what the mandate will look like in the future, and then consequently how Manx Care would respond to that in terms of an operating plan. But healthcare needs to look very different in 10 years' time, and we need to make the left shift.
So just a quick follow-up on that. I'm not familiar with that particular, in this context, left shift.
So left, and apologies if it's the political connotation. The Minister will tell me off. So what we really want and should be doing is delivering care in communities, removing care from hospital, using digital, and focusing on prevention.
It's earlier intervention and prevention.
Early intervention and prevention, delivering home first and care in our communities. And the third, and it's incredibly important, the use of digital. And we had a visit from the Deanery, who are responsible for monitoring all of our doctors in training. And we are the only area in the Northwest without electronic prescribing. And it was noted by the Deanery. So we're considerably off the pace with the Manx Care record, with electronic prescribing, and more broadly using digital capabilities to really enhance patient care. And there are some amazing technologies out there, but we are nowhere near ready, and quite far behind in that. That would significantly reduce cost in healthcare, and we need to invest now for health services to look very different in 10 years' time.
Okay. I'm conscious of time, so emergencies notwithstanding, I think this is likely to be your last appearance in front of this committee.
Yes.
Can I just say, as a regular attender before this and many other committees, the candour of your answers and acknowledging challenges and coming up with solutions has been much appreciated, and thank you, and good luck with whatever comes next.
Thank you.
And with that, thank you for your time today, and the committee will now sit in private.
Thank you.
Welcome back to this meeting of the Public Accounts Committee. We now welcome the Department of Health and Social Care team. Welcome to this oral evidence session. If I could ask Minister, if you introduce yourself, and the team could then likewise do the same, please.
Thank you very much, Chair. My name is Claire Christian, MHK, and I've been in position since December 2025.
Afternoon, Tim O'Neill. I'm Interim Chief Officer at the Department of Health and Social Care.
I'm Stephen Banks. I'm Senior Finance Business Partner of the Treasury, and I support the Department of Health and Social Care, and I've been in post since November.
Good afternoon, I'm Hasan. I'm the Financial Recovery and Improvement Director employed by DHSC, working within Manx Care.
Thank you very much. Mrs. Corwett.
Thank you. Our first question is, how much input does Manx Care have during the development of the annual DHSC mandate to Manx Care?
Okay, I'll start. A great deal of input, I would say. The process starts, almost sort of 9 months. Once we sort of put one to bed, it starts about sort of give ourselves a little bit of a break, but they do obviously have a great deal of input. One thing I am looking at developing, once now I've had this 1 year under my belt, I would say, we're actually looking at developing that a lot further. And we're speaking to Manx Care now about sort of actually getting a sort of a list of sort of 20 or so subject matter experts across their organisation to actually sort of go directly to them, to have them involved as opposed to through management, and I think that will be a much better way of widening that expertise and that involvement, and certainly obviously public health is obviously very much involved as well, but I think holistically what we're trying to do now with the next mandate is to have that a 3 to 5 year plan as opposed to just this 1 yearly mandate. It's really, really important, and I think having those earlier conversations with those subject matter experts is going to be fundamental to that planning.
Thank you. So how does the annual budget setting process work, and to what extent is this aligned with what's required in the mandate?
So, I mean, Stephen can probably talk about the technical aspects in terms of the budget planning process. But I would say that from my experience, you start as the minister having the conversations within the Council of Ministers, this year was probably Mr. Hooper will have experienced the similar scenario where there's been a sort of a generalised uplift. And you must work within that to your, within your budget and plan a mandate around that. But one thing we did very differently this year was the process that Treasury started to impend on, but I requested for it to be done differently, which they very much took that mantle up and helped us with that, so that we went in with the business cases as we would as the other departments do, and we discussed what that budget that they were allocating to us would actually pay for in terms of additional business cases or additional demand, etc. That was really, really beneficial for this year, because what that really exposed was what wasn't going to be covered in their initial assumptions for us, and we were able to negotiate a bigger budget this year on the basis of that and changing that process. So that was rather successful from my perspective. Whilst it was extremely hard, it was not easy. We had to many times meet with Council Ministers and Treasury to explain why this was important and to bring them along with that journey. But it was, I think that was a fundamental change in this year, which I think you can see.
So are you working the mandate to the budget or the budget to the mandate?
So in this year, it was very much more alongside each other. So this is what we would like, this is the mandate, this is what we would like to do, these are the business cases we would like to do, and the budget was worked alongside that. But initially it was very much this is your budget, and obviously that covers baseline, but then it wasn't necessarily covering the additional, as you know, the percentage with the Sir Jonathan Michaels. We know that that's been fundamentally underfunded over the last 3 to 4 years. So
was the 25-26 budget allocated sufficient to deliver the mandate?
I would say we did things differently in that year. I certainly, when I came in, it was in the December, so it was late into the process of that mandate, and a lot of the negotiation had already taken part, and the budget was pretty much already sort of set as in that perspective. So it was more. At that point, we were saying in that mandate, this is what we can do, and here are the risks. These are the unfunded parts. Whereas this mandate, we took a very different perspective, and we said, explaining it clearly to the council ministers and to Treasury, that we weren't going to produce a mandate that didn't have approved funding, because we didn't want to have those risks and to put Manx in that same situation.
So we can see from the operating plan notes that the expected spend for 24-25 was 362.3 million, and that's £500,000 above the budget, the allocated figure for 25-26. So was that budget realistic?
I think no budget is is necessarily realistic, because you are always going to have risks, whether and I know, just sitting listening to Mrs. Cope prior, she's listed out some risks that are still in existence for now. So yes, it can be as realistic as it can be, but you will always have outside pressures, whether that be pay awards, whether that be drug costs. So I think we have to be more realistic about what the external pressures are to any budget, and being more open and transparent about that is very important.
Can I just ask on that, actually? So I suppose the question that's being asked there is the budget between 24-25 and 25-26, between what was actually spent and what was budgeted for. The budget was less than what was actually spent. Do you think it's realistic to expect the health service budget to decrease? So do you think it's realistic to say, actually, last year you spent 362 million, this year we're going to give you less money than that? Do you think it's realistic to expect the health service to spend less money this year than they spent last year? Not in real terms, but in actual cash terms, actually spending less?
No, but I agree with you in the sense that why did we accept that? But we obviously were in a situation where we have to think about the wider government scenario. There was not the extra budget, as I understand it at the time, to allocate to give more to that year, and we had to work within the budget that was allocated to us for 25-26.
Surely then you must be expecting to overspend.
We highlighted the risks, and we've highlighted the unfunded areas, and a lot of those risks were dealt with in year. One of those risks was only dealt with last week, which was the NEPs. So some of them, we can highlight those and say that these are unfunded areas. But we did, I think, being open and transparent about that at the same time of saying this is the budget.
I think you've got me with NEPs.
Non-emergency patient transfer.
Oh, thank you.
So, touching on the actual budget allocation itself then, the Pink Book in 25-26 actually allocated £357 million to Manx Care. That's what Tynwald approved in the February budget. But the operating plan that was then laid before Tynwald actually stated a budget of £361.8 million. Why were those two numbers different?
So I'll have to come back to you on that, because I heard you ask the same question to Teresa, but we can certainly investigate that. From my recollection, I think it was a budget within the DHSC budget that transferred to the Manx Care line. So, but I can certainly come back to you and advise you on that.
Yes, that's correct. The 4.309 other budget in DHSC was transferred to Manx Care.
Yeah.
The question that I'm asking is, why was Tynwald asked to approve a mandate budget of 357 million when the department and Manx Care clearly knew they were going to be spending at least 361.8? Why did that happen? Why didn't the department ask Tynwald to approve the actual mandate budget rather than a lesser number?
Sure. I think, again, that comes down to timing. So you have the budget of 357 at that point was taken in the February sitting, and then the mandate came after that. Whereas this year we brought the mandate at the same time as the budget, so that you could see that it was being there was no discrepancy in that moment. But I can certainly look back and see when that decision was made. I think it was, as I say, this was pre Tim, but I know that Paul Richardson was part of those decisions.
So staying on that theme, that budget also included a £10 million contingency figure for Manx Care. At what point did the department know that Manx Care intended to spend that £10 million contingency in addition to the £357 million that Tynwald had approved, and in addition to the £4 million that the department had decided to hand over without Tynwald approval?
Clearly there is a separation from the DHSC in terms of timeline. When we would know from Manx Care, we are anticipating using X for, I would say, for sort of high patient costs. So I think in terms of, I know Manx Care established that they would probably need that early on, but again, there's probably a time lapse from when that started to transpire through to our finance business partner. But yes, I think that's it. It was early on that we anticipated that the 10 million would be allocated.
Okay, because Manx Care obviously knew about that when they published their operating plan, because it states in the operating plan that Manx Care intends to draw upon that funding. They were very clear from day one, which again brings me back to, why did you only ask Tynwald to approve £357 million as a budget, when even at that point you knew it was going to be at least £15 million more that you needed? Why didn't you just ask Tynwald for the full amount that you knew you were going to be spending at that point?
I think this was the new scenario of this a £10 million contingency budget. So this was the first year that I understand was being done. So I don't think it was meant intentionally that, oh yes, we know we're definitely going to spend that 10 million at that point when the budget was agreed in Tynwald in February. I certainly would ask that you possibly question Treasury in terms of how they wanted that 10 million and that function of that, how that was going to work. But I would say that it is a really helpful contingency, and obviously for this year we have the same 10 million. At this point I can tell you we are 6 weeks into the year. We have not been advised by Manx Care what that might be used for. So there is obviously that time lapse. They may know already that some of it is for high cost patients, but we don't have that information as of yet.
Okay, can you just outline what the process is when you via additional funding from the department to Manx Care? What is the actual process you go through when you take some of the department's money that Tynwald has allocated to the department and you allocate that instead to Manx Care? What's the process that you follow?
So the process that we have followed within the department, so I can say, was towards the end of this year where this happened, basically Manx Care came forward with business cases to the department, and that would go through the department meeting, and we would evaluate which of those we would allocate funding to from the department.
So when you handed over the 4.3 million after in between the February budget and the March publication of the operating plan, there was a list of business cases at the department?
Not in that scenario, sorry. As I said, I'll have to go back to finding out how Paul Richardson authorised that, but I don't have that information.
Right. So
but in year now, that's the process for how money is allocated from the department.
So you say that you're not sure how Paul Richardson, who would have been the CO at the time of the department, but surely it would have been the department making that decision at a board meeting at a senior level. There would have been a decision taken.
Didn't happen.
Right. Okay. So there isn't a paper trail that backs up how that money was allocated.
Not that I recall. No. Okay.
But it'd be grateful if there is anything, if you go back and find, that would be quite useful.
Absolutely.
Sticking on the budget figures, if you look at the probable expenditure for Manx Care for 25-26, according to this year's budget document, that's £384.5 million. The budget that's been set is £404.2 million. So if you take the probable expenditure figures as being correct. I've no reason to assume they won't be. That this represents only an increase of just under £20 million, which is quite a lot less than the £45 million headline number that the budget announced. Do you think presenting the budget in that way, that as was done in February, about that significant £45 million increase is a bit misleading when you look at the actual detail behind what sits in the budget and how much money has actually been allocated, which sits at just under half of what was announced as a headline figure?
Yeah, I think we are constantly in this sort of a scenario where spending is end of year spending is catching up with budgets and budget approvals. So I think you're absolutely right to say that whilst the public line is you have 42 million more, and this seems a great amount of money, but it is the adjustment as far as I'm aware in terms of the core baseline as well. So I think that's what was taken into account for this year, which was a lot more beneficial. But you're right to highlight that, and I think that's very helpful for the PAC to highlight that.
The reason I ask is because in the same budget document, so in the same table that shows you this information, there's a line headed up additional mandate, which for the current financial year 25-26 is £22.7 million. Can you give us some information about what that additional mandate represents? Because obviously Tynwald hasn't approved any additional mandated budget for Manx Care during the year. There hasn't been a supplementary vote.
Sorry, where is that? Sorry.
It's in the pink book in the budget, in the same table 36, that shows the department's expenditure. That additional mandate of 22.7 million. I was quite surprised to see that in the budget, as if it had been approved and allocated, but actually it's a number that appears almost out of the blue.
Can you explain that? I'm not sure, sorry.
Appears to be a balancing figure, doesn't it?
I couldn't possibly comment, Mr. Speaker.
I'm not sorry. Can you explain what that line is, do you know?
We'll need to get back to you, Mr. Hooper.
That's fine if you can. In previous years, it was money that had been voted on by Tynwald and added to that. So there was an additional mandate the year before, which again was what that number represented. But in the 25-26 year, I think we are still yet to see a supplementary vote. So I suppose the follow-up question is: does that £22.7 million represent what the supplementary vote is going to be? Is that the number we're expecting to see, or have things changed again since February, which they may very well have done?
So I don't want to predicate what the supplementary vote will be, but certainly we can get back to you on what that figure is.
Thanks.
Okay.
That's all I had, I think.
Mr. Mercer.
Thank you. I've just got a couple of questions about the process around changes to the mandate. So, firstly, when there are in-year changes to the services which will be delivered, how is the mandate and the budget updated to reflect that?
You'll be aware Part 3, Section 15 of the Manx Care Act lists out how to change or make changes through mandate changes. Mr. Mercer.
Yes.
That's the process that's followed.
And so that's the legislative process. I was just really wanting to understand perhaps a little bit more of the procedural aspect of that when it comes to communications between DHSC and Manx Care.
So, in year, and we are being far more, I think, alert to this with this this mandate, because we are committed to delivering on the 404. We are working with Manx Care to look at what might be in-year changes, and if we were going to bring those in-year changes, so we would discuss that with Manx Care at the board-to-board and discuss what changes would need to be made, and we would bring those to Tynwald as in the mandate in the Manx Care Act as it's described.
Okay, thank you. Has the Department of Health and Social Care issued any statutory directions to Manx Care?
Not that I know. But just to caveat that, we would absolutely always communicate with Manx Care, on a regular basis, either at the board-to-board or directly with emails that, requesting things on a daily basis. That you could classify that as requesting statutory information, but we have not given any directions, so to speak, that would be legal ones within the Manx Care Act.
Thank you. So when changes to the mandate are proposed, either by Manx Care, for example, to enable delivery of savings, cost improvement, or by the Department of Health and Social Care, for example, when Tynwald has resolved that something should be done, how do you address those challenges, in year, and resolve any tension that can create?
It's very important because we sometimes look at, in Parliament, we sometimes look at things in isolation. And through motions, through individual members' motions can bring through. We've currently just had one, the ADHD pathway, and that's something I think is working well in the aspect of a scenario. So we're obviously bringing that to Tynwald. We can see a lot of public want that service, but obviously it's fundamental on Treasury concurrence. So what we would be doing is, as we explained during that motion, is we will be obviously bringing that forward with the planning for 27-28 and 29-30, so that can hopefully be a new service that would be in Manx Care and provided on the Isle of Man.
That's great, thank you. Just earlier in our previous session, there was the talk of the core part of the mandate, and we've also heard about some of the things that towards the end of the year were attempted to be switched off, that caused a bit of a furore amongst the public. Aren't those core services in the mandate? How do you prioritise which services can be switched off if they're already described as core and you've already got the budget for them?
I think you're absolutely right, and that's absolutely something that we all want to avoid, making sure that core services aren't. In the instance of this year, I would say that what we would do is not we have are introducing expansion of services, and if needed, then we would slow down the start of those expansion services to be able to, is pulling those levers, isn't it, to be able to come within that budget. So we're definitely far more, certainly with the FRP programme, we're definitely more ready to be able to fluctuate like that, but working with, obviously, with Manx Care on that. But we will always give priority to core services.
Yeah, that's the bit I was trying to understand, really, is that it's already described as a core service, and yet one of them was deprioritised.
Sorry, which one was deprioritised?
It was the elective surgery. Yeah.
Sure. Yeah. So obviously that decision. I recall now back to that decision. I obviously arrived in a very difficult scenario whereby these different solutions were being proposed. Otherwise, we were going to be, or Manx Care were going to be more over budget. So it was a very difficult decision to decide which ones. But you're right, at that time that those decisions were made for, I believe it was the tertiary care elective surgery. Yes, yeah, thank you. Yeah, go ahead.
If I may expand, my understanding of that is that in elective care, there is a clinical validation process that doctors have to follow. They don't just deprioritise and not do things if it's clinically unsafe. And that clinical validation or prioritisation process determines whether you can slow down the activity you're performing. So the entire service isn't going down. It is the rate at which one is performing that service. And so it's a balancing act between the money that is spent and clinical safety, and that's a clinical decision.
Okay, that's great. Thank you.
That's my understanding.
Can I just jump in on that? Because obviously, as you're aware, we've having some real issues with dentistry services at Ramsey at the moment, where we haven't had an NHS dentist actually available for most people for quite some time. There was an attempt to relocate it to Douglas. That didn't work very well. So actually, you have a real current example of a service there that is a mandated service delivery that Manx Care is completely unable to provide, not for financial reasons, but for operational reasons. And surely those sorts of things do require some department oversight. So when these decisions are being made as to how do we address these problems, how involved is the department in that decision making, or is it left up to Manx Care entirely to decide when to switch things on and off and how to switch things on and off?
So in that specific scenario, we've been extremely aligned with the provisions up in the north and meeting on a virtually a weekly basis on this to be working with them. The decisions, I would say, are with Manx Care because they are operational decisions. However, we are fully aware of what's going on and try to help with that communication to the public and to Tynwald members on it. But I would absolutely understand why that's a frustration, because that's a scenario that's probably a little bit out of Manx Care's gift at the moment. But yeah, I think that we're progressing with Smile and progressing with them to get that back up and running.
So what happens to funding in those circumstances? Because as Mr. Mercer said, Manx Care was given the money up front as part of the mandate to deliver these services,
Sure.
and obviously they're not. So what happens to the budget in that case? Is it reallocated by... Well,
one?
when this sort of thing happens, does that get reallocated by Manx Care somewhere else? Does it get put in a pot for... what happens to it?
I would presume that what there would be key for that is just to get those patients, so there'll be more. Please increase your patient list so that you can get those patients seen, that there might be a backlog. But that's an operational, we would need to confirm that with them, what that in that specific scenario where that budget has. I think it might be about 4 weeks that we've not had dental care, obviously.
It would be the department's expectation that you would reinvest that budget into the service that had been temporarily suspended, as opposed to saying, I didn't spend it here, so I can now spend it somewhere else.
Yeah.
I think it'd be useful if you could provide a clarification, perhaps to the committee on that point in writing. Final question from me: what do you think the Department of Manx Care learned from the attempts at cost reduction of January 2025?
Sorry.
So that same scenario from before the elective. So that was an attempt at cost reduction. What were the lessons that's been learned by the department from that exercise?
I would say we've demonstrated huge learning just through the new mandate. We've demonstrated that making sure that we are more aligned with the mandate, the operating plan and the budget. Whilst I do acknowledge there are still some outside factors, which I said earlier, but I think that's been fundamentally a very, very strict. We do not want something in the mandate that is not funded. And I was ready to remove things had that not been approved by Treasury prior to the mandate being published, because I was very adamant that we were not going to put things in there. I would rather come back and say 3 or 4 months later, guess what, Treasury have approved this and I'm going to make a change to the mandate and we're putting that in now, rather than possibly not having that funding, because it has been, and I would say that the process for approvals can take longer than we would all wish them to.
So from that then, would it be fair to say that you seem to have a service priority list of sort of within Manx Care of things that could be deprioritised? Just in thinking in terms of process then, if it got to Q4 this financial year and things were looking really tight, would the same thing happen again? It would be back to electives, or is there perhaps a more understood plan that can be developed or stood up throughout the year if that looked like it was going to be happening?
Yes, so we are working with, in terms of the FRP, where that streamline can work. Do you want to expand?
Very briefly, if you could.
Yeah, very briefly. The Financial Review Programme, or sometimes referred to as the SIPS Programme, is within that budget mandate. There is a £9.8 million, let's say, so long as that is delivering to budget. But cost pressures outside that may arise, and I think your question is, how do you mitigate those?
Yeah, in a controlled way, rather than what we saw in January last year, which seemed a bit knee-jerk, in Q4, trying to.
So we have a quarterly mandate performance meeting. We are currently working with, as I said, we're sort of 6 weeks into the year now, and working with Manx Care to highlight what are our options, and as you say, to prioritise those. But that is work that is ongoing. We've not completed it yet. But we would be happy to share that with the PAC when that works, so you could see what levers we do have available to us.
If I could just add to that, Chair, and that's exactly, so in the approach we're taking in the financial recovery programme it's a risk mitigation strategy. So every month when we see the variances, we would be looking for how we're going to cover it. If the savings are delivering, but we are still off budget, which happens very often because of the run rate, what are the mitigations? And in that process, there is a continuous development of ideas and schemes at grades of complexity to start to pull in to try and do more. But in that process, depending on how far down the year we are, the intensity of what you do does depend upon the size of the problem you're facing and how far down in the year you are. So sometimes you do have to take much tougher action given the size of the problem you face, which would involve things like potentially slowing down expenditure. Activity is a big part of healthcare expenditure.
Again, that is something that the point that Mr. Hooper was making earlier in this session is that, I think Manx Care kind of knew on day one that it was going to come over. It shouldn't have really come as a massive surprise to anyone in quarter four, but as long as there is now a better solution and a more thought out process, I think that is what I'm trying to get the reassurance on at this stage.
Yeah, and I think as the Minister highlighted as well, it's in the planning that's the key. If we planned the next year's activity more appropriately, I think that was one of the problems of 25-26, that if you compare 24-25, 25-26, I think the planned activity was rather low.
Okay,
Can I ask another thing on that though? Because again, you're talking about planning ahead. If you look at the current budget of 404 million and look at Manx Care's operating plan, it describes quite clearly how they intend to meet that budget, and it includes using 9.6 million of the Treasury contingency fund. It's not a contingency if you plan to use it. It also requires them to spend 4.7 million from Treasury in your business cases. So as part of the planning, you're planning to spend more money than Tynwald has approved because you're planning to spend contingency funding and additional, and that's factored into the mandate. This isn't beyond the mandate spending. This is in order to deliver the mandate. So it doesn't feel like you're actually in much of a different place than you were in 2025 because you're still planning on spending the full contingency amount and additional money above and beyond what is in that mandate budget line just to hit your 404 million target spend. So I'm not really sure how things have moved on if you're saying you're better planning now, but as part of that planning you're still proposing to spend money that is in contingency. There's a lovely waterfall graph on Manx Care's in Manx Care's operating plan that explains how they get from where they are to where they need to be, and it quite clearly shows they're intending to spend all of this money more than is simply in the budget. It doesn't feel like things have moved on a lot.
Yeah, so, Chair, if I may come in on that one. It's a really good challenge, Mr. Hooper, and thank you, Chair, for allowing me to speak. I think I don't want to sound mealy-mouthed. We're on a journey here. I think we're doing much better at offering that challenge than perhaps we've done many years ago. And Manx Care hopefully would say that we've had a grown-up conversation about moving to the middle. And what I mean by that is it's perfectly fair to say that the starting point in terms of Manx Care, how Manx Care could deliver the mandate and what we want to deliver for the 404, we were a little way apart, and we worked really hard to close that gap. We are resolute in our determination to deliver on that, but we also know the background and history to delivering that is really tough. So we've got our eyes open in that respect. The other thing I would give committee assurance about is we are spending an awful amount of good quality resource in this space in order to try and get to that point, but we know it's not going to be straightforward, and that challenge is respectful, but it's meant.
Forgive me if I've misunderstood your question, but my understanding of contingency is that that's not in the 404, that's held by Treasury. So nobody's spending that up front. So unless I've misunderstood your question, I apologise. But the contingency is not part of the 404.
No, I know it's not spent. I know it's not held by Manx Care, it's held by the Treasury. But as part of their planning assumptions, they're saying actually part of our assumptions we're going to need to spend this. And I think they've allocated it all for what they call high cost patients, which kind of makes sense.
Against risks.
Yes. Yeah.
Understood.
Okay. Mr. Morehouse.
Thank you. The next section is actual costs of service delivery. Without activity-based costings, how do you actually calculate the cost of delivering services in order to set a budget for Manx Care?
So that's a loaded question. If there was ever one, Mr. Morehouse, you can't. It's you absolutely must know that answer. It's very difficult because we don't have, we're not working bottom up in terms of activity-based costing. That's something that we absolutely. It's part of the financial recovery programme. It's one of the work streams for that. So it's really important that we get that. It's been a really fundamental, crucial change, I think, this year, that understanding our demand, understanding our capacity, understanding our capabilities, and being able to see where trends are, and know how much we're spending in these areas, and activity-based costing is absolutely part of that. It's essential for us to be able to plan better, and until we have that, we are in some way reliant on what we've spent last year, an uplift, and the additional budgets for business cases. We are reliant on that as the way that budgets are allocated. But until we get the activity-based costing, and then we start the commissioning work, that where we would actually commission, this is how many hip replacements we want to do, and this is the cost, and we know that, and we can actually work the budget from the bottom up and be able to say, this is the kind of activity that we would be doing for that budget.
And given, as we heard previously, getting to activity-based costing is going to be a challenge, how soon can it be achieved? And can it be achieved?
So, do you want to give an update just on that, Deb?
So the ABC costing system is a key priority. But to be able to do that, it does require a taxonomy of and a data and an information infrastructure. Simple things like data warehouse that do not currently exist at all. That IT infrastructure just isn't there. So it requires that to be in place before one can actually do proper ABC, and then moving on to that patient level information costing systems, which is at each individual patient level. That's really what we're trying to get at. The question you're asking, the journey to do that, to actually being able to get the taxonomy and the data infrastructure in place, and then build a system on that to do the very simple things like costing an activity and a service, so we can plan budgets properly going forward and plan services within budgets going forward, is about an 18-month journey.
So by we get to 2028, things will be in place in terms of the technology and the data.
That is the plan. Of course, none of the approvals for that investment have yet been made, but the plan is to do those business cases and do that once we have stabilised the financial position. That's the key focus right now, because we can't build ABC on chaos.
And given the nature of the technology, how much is this likely to cost? Just an indicative figure.
That business case does need to be done. I don't have the numbers, but that needs to be built.
Apologies. I didn't mean to cut across you. It's not just one business case, though, because as we heard earlier, there's some quite big, chunky things that are part of that. It's not just sort of stopping using carbon paper for procurement. That's one of the early things that would probably need to be done in a financial system to sort of do e-procurement. But it was also needed to be built on a single patient record, and that's an enormous project. And we're really expecting that to be done within 18 months with funding and everything.
The Manx Care Record is currently being developed by the Strategic Change in the Cabinet Office, Strategic Change Director in the Cabinet Office, and they are collating now all the information to produce the final business case for that submission. So that's where we are currently with that. But you're absolutely right. But activity-based costing is part of that. So it's the 18 months is part of that. But you're right. The single patient record, that would not be in 18 months. Yeah. That's a longer term.
As Cope was saying, that was one of the essential building blocks in order to be able to do activity-based costing. So you're not going to be able to do activity-based costing without good coding, which is based on single patient record. So until you get the single patient record, I think the 18 months is looking decidedly shaky at this point.
Chair, I think I think you're more likely referring to patient-level information costing system, where we are costing each patient. That's a journey beyond ABC. The first phase of it is just getting activity-based costing, which is a costing methodology of being able to take each activity and allocate costs to it. And that is a slightly higher level than actually doing it at patient level. You're absolutely right. The Manx Care record is going to be at the level of detail at each patient level, and the patient level information costing system would draw on that and use that. That's another 18 months on top of the first 18. But to answer your question, the ABC gives us the ability, at least at a reasonable basis, because it allocates cost in an accounting way, but it's not patient level, but it's an account, to be able to cost services up. And that, of course, implies that you can then budget more appropriately based on the activity you're going to face. So it gets us to the first phase of insight and proper planning.
Thank you.
Can I just ask, how do you, obviously understanding the cost of a service is part of the puzzle. The other part of the puzzle is being able to forecast the level of demand that you're likely to see coming forward. How involved is the department in that forecasting? Do you rely entirely on public health? Does Manx Care drive some of that? How does that kind of activity level forecasting, demand level forecasting work?
We're there with that, aren't we?
That's a great question. So we're doing a lot of work with Manx Care, supporting Manx Care with resources to do demand and capacity modelling. And so there is quite a lot of work being done on getting. We know our demand and activity data, and we know what the trends are, and then you can forecast and assume that the capacity data, which is whatever it looks in people and systems and equipment and process, and how do we use it and how is it organised in state, therefore, and the productivity that goes with it. That's a little. That data is being collected, so a key priority for this year, which is work is now going on right now on this, is to collect all this information so we have a model, which is a demand and capacity model, that the directorates build their operational plans on, saying that's my demand, that's my capacity, that's my productivity assumption. That will then inform budgets going forward. So it's a rolling program. It will take us 12 to 24 months to complete it, but I think we can get at least the big spend areas done within the next 12 months. It's a high priority
Since
area.
launching in the FRP programme, this has been really one of the fundamental. You've probably heard me say it before. I want to have that crystal ball to be able to see what our demand, and we are there with that data now for probably the first time. It's been there, but it's just not been sort of formulated in the way that we wanted. We should be looking at it, but we hope to be bringing that forward in a Tynwald members briefing over the next coming months, so that you can see what has been the demand, what has been the capacity, and that will be really insightful information for members.
Can I ask where you think we are in terms of the assessment of value for money of the services, and whether the services that we are providing on the Isle of Man are more expensive, significantly more expensive than comparators in the UK? Is there any sort of exercise that can be done along a bit like the unwarranted variations exercises that's been done to sort of try and flush that out and drive value for money whilst we do that in parallel with this process? Is that something that you see happening?
Yes, absolutely. So the unwarranted variation reference that you make is what in the UK we would call GIRFT.
Yeah.
And GIRFT is absolutely, the getting it right first time, is absolutely one of the standards, benchmarking standards we're using to benchmark our services. So this is part of the programme. It's only just started. So a team is being built by Manx Care right now to help do that exercise, so we can look at where the variations are to identify opportunities for better practice.
Okay. We also, Mr. Mercer, do you want to come in with your question at this point? I think
just picking up on the last part of our previous session, is the Department of Health and Social Care planning work on a long-term health and social care strategy?
Yes, absolutely.
When might we expect to see this?
So it's fundamental as part of the governance review, which you'll be aware of, Ms Mercer. But yes, we are looking at a 3 to 5 year healthcare strategy. That will be part of this piece of work, but it certainly won't be in this administration. But we will be looking at bringing forward for next administration, and that would fundamentally hopefully Treasury have absolutely concurred that they will give us a 3 to 5 year financial settlement on that as well. So we'll be working with them to do that. But it is crucial that we have that, and crucial that we know where this demand piece of work that we're working on now is part of that, and in informing that for the future.
Yeah. Do you think that's sufficiently long-term view, 3 to 5 years?
Ms Cope said there needed to be a vision for 10 years.
Yeah, absolutely. I mean, I think we can definitely have an overall sort of higher level strategy for 10 years. But I think the first step is the 3 to 5 year programme that the FRP is going to deliver.
Just what the Minister is right. Our initial phase is the 3-year programme, which is what we said is the initial roadmap. That's a roadmap to just stabilise and get things like ABC and the basics in place. Following that is the longer term strategy, which is the 10-20-year plan. And that is about us projecting based on this information we would have in terms of PLIX, patient level inflammation costs, or ABC. That gives us the ability to project and say, if we assume demographic changes, which we already have the data on those demographics, disease profiles, complexity, and we project forward, and we just use our current scenario of do nothing, is it affordable? And therefore what the answer to that would be, and this is the piece of work that we would do, I think, beyond the three-year phase, because we'll have the tools to do it, which then says, well, if it's not affordable, how do we fund this? And how do we change the model of care? So that's the longer term strategy, but it would be informed on the basis of just us getting to the first phase.
That's great, thank you very much.
Sorry, can I just, before we gloss over this, I'm pretty sure I just heard the Minister say that the Treasury was supportive of giving you a 3 to 5 year financial settlement.
Yes, they said that in Tynwald.
The Treasury have historically been very resistant to actually, they've made that promise a number of times, but they've been very resistant historically to actually put their money where their mouth is, quite literally in this case. How confident are you that the Treasury have changed their spots and are now actually actively backing a multi-year financial settlement?
So it was fundamentally agreed within Tynwald, so it has Coman and Tynwald backing. I do remember that the Treasury Minister, the then Treasury Minister, which was Dr Allinson, he did stand up and say that, so I remember that quite rightly. I'm sure, I think you applauded at that time.
Is the current Treasury Minister still very much on board with that?
That's part of the governance, that's been approved, so I would say, hope he would be.
Wonderful. We also heard Ms Cope talk about how the mandate operating plan and budget, and you heard me put her words back to her for the much closer, and there are fewer areas of financial risk, and I think the one that was summarised at the end was around pay. There was a 2% allocation in the budget for pay. We have seen inflation go up. What's your expectation as to what happens if pay settlement comes in much higher than 2%? What happens next over the next sort of 9 months?
I have to be very careful because obviously there's current pay negotiations currently.
It's contingency planning.
But yes, obviously assumptions would be made within the budget.
Right, and again, back to the earlier conversations, there is a list of sort of service deprioritisation that can be stepped up over that time if needed. But hopefully it won't be, but there is a more organised plan around that. Okay, wonderful. Okay, in which case, is there anything else you'd like to add before I draw this part of the session to a close?
No, I think one of the things that, well, yes, actually I would, to say that I think we have made great strides in this year with the finance business partner, and we are looking to inform the PAC that what we are looking is quite some structural changes going forward, and it's, we currently have sort of a scenario where you have finance within Manx Care, you have finance within DHSC, and you have finance in Treasury, and through the governance review it talked about either repatriating that back within the department or better service level agreements, and we are looking very swiftly over the coming month to actually centralise that finance team. And I think that's going to be really fundamental, because whilst the Department of Health and Social Care has a certain scenario where obviously we can't lift the bonnet of what's going on, but it's really important in terms of planning and in terms of future planning, that we actually are able to do that, and that's why this structural change will be really critical and very important. I'm really looking forward to seeing how that will hopefully working together and under one area will work a lot better. So it's bringing in VAS, it's bringing in the Manx Care team and obviously the business partner, and getting them to work obviously in one space together. It's not just locality, but it's actually really important that we all have one voice and there's one number, so to speak.
Thank you very much for your time and your evidence this afternoon. That's much appreciated. And with that, the committee will now